My name is Dr. Shouvik Haldar. I'm a consultant cardiologist at the Royal Brompton and Harefield Hospital in London, UK. The name of our study is the CASA-AF study, which stands for catheter ablation versus thoracoscopic surgical ablation in long-standing persistent atrial fibrillation. The rationale for the CASA-AF study is the fact that there are many patients with long-standing persistent atrial fibrillation in whom we do not know what the best optimal management is in terms of intervention. We know that if we do catheter ablation, often these patients have fairly suboptimal single procedure success rates, and they often need multiple procedures. And there have been some recent studies over the last sort of 5 to 10 years suggesting that thoracoscopic surgical ablation techniques may actually provide better efficacy, and hence that is the rationale for testing one against the other in this study. The design of the study was a randomized control trial in a one-to-one fashion. We based our sample size and our effect size based on literature that was available at the time, as well as our own pilot study. So we recruited 120 patients and randomized equally between the two groups of surgical and catheter ablation. The patient cohort for this study was long-standing persistent atrial fibrillation. So these patients, by definition, are the hardest to treat. They have had long-standing AF for greater than 12 months continuously, and they've essentially failed drug therapy and electrical DC cardioversion. The study endpoint, we stuck to the fairly rigid Heart Rhythm Society endpoint in AF ablation trials, and that is freedom from atrial fibrillation or atrial arrhythmias of greater than 30 seconds off antiarrhythmic drugs. We met this using a fairly stringent process of arrhythmia monitoring using an implantable loop recorder, which is increasingly being done in research studies to provide a very sort of robust scientific answer. So there are several results from this trial. The main primary endpoint result was the fact that after a single procedure, freedom from atrial fibrillation and atrial arrhythmias was similar in both groups, around the mark of 26%, and that was off antiarrhythmic drugs. But what is important, I think, from the patient perspective is because we have implantable loop recorders in place, we were able to see that there was a significant reduction in AF atrial arrhythmia burden of greater than 75% in both groups, again, fairly similar, with success rates from that perspective in the region of 65 to 75. And that's very important from the patient perspective. In addition, we found that catheter ablation, patients had better symptom relief and had better quality of life parameters. Furthermore, we found that over the period of 12 months, there was a high rate of adverse events in the surgical ablation arm. Also, one final point in terms of cost effectiveness, we found that surgical ablation was more costly. So if you put this all together, at this moment in time, it looks like catheter ablation would be the first-line recommendation in those with long-standing persistent atrial fibrillation, given that there is no significant difference in the hard primary endpoint and that patients seem to do better in terms of symptoms and quality of life. From this study, we found that after a single procedure off antiarrhythmic drugs, we found that there was no significant difference between the two groups in terms of freedom from atrial arrhythmia. And the rate of success was in the region of about 26% in both groups. So given that we found no significant difference, and the study was very much powered to look at whether surgery was superior to catheter ablation, we found not only that there was no significant difference between the two groups, but we did find also that patients in the catheter ablation group had better symptom profiles, better quality of life, as well as the fact that surgical ablation was more costly. So putting that all together, at this moment in time, we feel that catheter ablation would be the first line option for those with long-standing persistent atrial fibrillation in terms of intervention. In terms of next steps, I think surgical ablation is not yet ready for prime time. I think surgical techniques will need to evolve further, perhaps become less invasive, but I think more pressing, and this applies to any ablation, is that we need to know what the targets are for ablation beyond pulmonary vein isolation. And this is subject to much debate. There is a lot of work going on looking at personalizing ablation strategies, and this work will continue. But I think those are the next steps in order to try and refine what we target and where, rather than how.